We've appreciated the time that you've taken out to attend this important roundtable. We understand that you have many things on your plate today. We'd like for you to please spread the word for posting this event on your preferred social media platforms. Before we get started on the formal presentations, I'd like to just give you a run of what our schedule is today. We have two esteemed presenters who will present their information right after one another. After the presentations, we'll have the ability to engage in a question and answer period. So with our first speaker, I'd like to introduce him. Dr. XinQi Dong is Director of the Institute for Health, Healthcare Policy, and Aging Research at Rutgers University. He is also the Henry Rutgers Distinguished Professor of Population Health Sciences. Dr. Dong is an international scholar who's examined the intersections of elder abuse, violence, resilience, and health outcomes in the United States and China. Dr. Dong directs the Center for Minority Aging Research, which is the only RICMAR center funded by NIA that's dedicated to US Asian Americans. Dr. Dong collaborates with several of our senior scientists. I have the privilege of working with him on several NIA projects, most notably examining non-pharmacological interventions for persons living with dementias and their family caregivers. Our second speaker is Dr. Du Han. Dr. Han is a professor of family medicine, neurology, psychology, and gerontology at the University of Southern California. He has several institutional affiliations. Most notably, he's a diplomat of the American Board of Professional Psychology in clinical neuropsychology and a director of the neuropsychology in the Department of Family Medicine at USC. Along with several of our USC colleagues, Dr. Han is affiliated with the USC Center on Elder Treatment. He specializes on the study of factors that impact cognition and decision-making in older adults. Dr. XinQi.
Maria, is that there's some beeping. Is that a green light for me to go?
Yes, it is.
Okay, great. Thank you, Maria. And thank you for the university for co-hosting this with distinguished panels, and as well as old friends and colleagues that I see on the screen as well. My background, I'm a geriatric physician by training. And I remember during residency, I had, in addition to my traditional roles, I'd done a lot of home visits in taking care of patients. And that very much informed my view of going to geriatric medicine. And the one thing that I recognized very earlier on in my training was that it's not just when we see them in clinical settings, in the offices, but how they're like at home. What is their family structure like? How does the broader environment, safety, affects that 15, 20, 30 minutes of interaction with healthcare providers? And when we see patients who don't take medicine, unable to take medicine, there's a tendency for us to label them as non-compliant, very paternalistically doing so, not understanding what are the issues going on in their home environment. So when I talk about issues of elder abuse, I'm thinking the framework of not just the intimate partner variance in terms of what physical, psychological, sexual abuse. I'm also talking about neglect in the sense of caregiver neglect, elder self-neglect, as well as financial exploitation. And they all vary significantly. A few years back, I wrote a pretty large textbook with a lot of different collaborators. It's about 35 chapters, about 700 to 800 pages long in a textbook size. And it's published by Springer. I can refer you to some of that for more detail. But when you think about prevalence, if you will, we know it probably happens about anywhere between 8 to 15% of the population. So the numbers is pretty big and depends on which population we're talking about. If we're talking about people with dementia, those prevalence numbers are substantially higher, into 20, 30, perhaps even 40% range. And it depends on the issues with the caregiver neglect, the financial exploitation. Financial exploitation is one of the fastest growing. But yet at the same time, some of the caregiver neglect or self-neglect is most difficult to assess. We know very little about incidents or the new cases. We can only know that through longitudinal studies, and there's some earlier data suggesting so. The field of elder abuse really have substantially advanced over the last 20, 30 years or so compared to before, and it's far lags behind that of intimate partner violence or child abuse in those cases. And we know a lot about risk factors. We know older ages tend to be more likely for certain subtypes of elder abuse, such as neglect and financial exploitation, but they're not uniform, right? And we know for people such as psychological abuse or physical abuse that tend to occur in the younger of the old population. So there's a lot of variability. Gender, women are more likely, but there's also more women live longer than men in those cases. We know that underrepresented minorities, elder abuse occurs more often, especially in African American, Hispanic, and Asian populations. But is that truly because of race, ethnicity, or is it because of marker for socioeconomic status, or because of cultural norms of what's expected to be performed and an obligation to fill those filial roles, and when they're not met, are they considered? Is it a variation in the definition of criteria? Cognitive impairment, I'm going to leave to Dr. Han to talk about. He's really an expert in this area. So for every risk factors, whether it's disability and mental health or social isolation, we know a lot about those are risk factors that leads to them. But the picture is always a bit complex in the sense that, give you social support, for example. We used to think and write a lot about low-level social supports associated with increased risk for elder abuse and different subtypes of elder abuse. While that is the case in many circumstances, we also have known now that social support can be a good thing, can be a bad thing. Too much social support from the wrong sources can also be deleterious and increasing risk factor for different types of elder abuse. And some of the papers were published in Gerontology and Medical Sciences indicates that sources of social support and variations, and whether it's positive or negative social support, may predispose someone to have differential risk for elder abuse. But we can predict it. Some of the articles we published over the last few years that we can think about elder abuse as either self-reported by the older adults. It could be reported by a unknown party reporting anonymously, such as a family member or healthcare provider. Or it could be screened in those cases. That often in a busy clinical practice is not always easy to be able to ask the Pandora's box question, right? To say, do you feel safe at home? And if the answer is no, you can't just say, well, your 20 minutes is up and let's pick this up next time I see you. So I think from a provider perspective, there's a lot of hesitancy and inadequate training to be able to support them. So there are predictive indices, just like how we predict for cardiovascular disease through Framingham heart studies, that there are publications and looking at potentially validated indices to be able to predict based on their comorbidity, based on sociodemographic, based on cognitive function, based on disability. One thing we know for sure, that is looking at the consequences of elder abuse, that we know that it's associated with a premature morbidity and mortality, that people with elder abuse die prematurely. Both my work in the Chicago Health and Aging Project, as well as Mark Lax and other people's work, have shown that, they shorten lives. And it depends on what types we're talking about, that especially for self-neglect, that there's not only a potentially 8 to 15-fold increase in mortality, but specific cardiovascular related mortality. If you think about the stress the family goes through, the older adult goes through, that may lead to worsen in terms of mental health outcome. Many of the factors being associated with cardiovascular disease as well as mortality. We also know that elder abuse victims more likely to get hospitalized. They're more likely to end up in the emergency room. So for many of you who may be caregivers, who may be older adults yourselves, and who may be providers or teachers, think about the adverse outcomes associated. And think about also in the context, what problems we care tremendously about that leads to urgent actions. When you look at the potential latitude or the degree of morbidity, mortality outcomes, when one of our paper we published a number of years ago back. And one of my colleague, Tom Gill from Yale, wrote an editorial in JAMA suggesting that if this were a seizure or someone broke their hip, will we not pay their attention in a similar way in terms of urgency of the nature? So thinking about elder abuse, neglect, and exploitation, not only as a medical issue, but a public health issue as well in this case. The next issue is the screening, is that there's many different tools you can use. You know, if you're seeing patients, if you are in your practice, there are a lot of tools we can use. Some of those tools are as short as, 6 to 8 questions that you can use to get a better sense of safety and the vulnerability and coercion maybe going in their homes. The last thing I want to just mention briefly before I turn it to Dr. Hung is really thinking about elder abuse in the era of COVID. About a month ago back, we held a congressional hearing and hosted by 2 congressional members, and really talking about, in the era of COVID, that there are many factors that predispose older adults to be victimized, and sort of 2 extremes. One is that often older adults who live by themselves, they don't have adequate resources and they don't have the ability for family members to visit them and to be able to care for them. So issues of neglect becomes much more common. The opposite end, where multi-generational families who do live together, that conflicts occur because there are limited space, there are limited bandwidth, and frustration often occur in a way that may predispose them towards more psychological abuse or physical abuse or financial exploitation related issues. While we really don't have good data suggesting any of the issues regarding to risk factors or consequences in the era of COVID, but one thing we do see a lot of similarities, that is, there are a lot of shared risk factors between elder abuse and shared risk factors for COVID. And there's many shared consequences as well in terms of hospitalization, emergency room visits, as well as morbidity, mortality, hospice use. So I think there's a lot more research needing to be done. From the last congressional hearing, there's a number of calls for Advancing Elder Justice Act, which is the only federal legislation protection of older adults, despite the fact that it's being appropriated for a decade now. Very little money is being appropriated towards the realization of the protection needed. National Adult Protective Services often don't have enough resources. And at USC, you guys are very fortunate to have the National Center for Elder Abuse run by Muscada, and Duke externally involved as part of that. But there needs to be a lot more at the national level. So work with your protective services agencies, work with your aging professionals, AAAs and networks, and think about how do you create a system, whether it's in a microcosm in terms that you're seeing patients and leveraging social workers and physical therapists and family members to ensure elderly are safe, or think about much larger work with the protective services, AARP, an area agency on aging, or city and state Department of Aging Services to be able to protect older adults. So let me stop here, Maria. Pass the baton to Duke, please.
Thank you, XinQi. Duke Han, you could go now.
Okay, I'll go ahead and share a screen. Let's see. Okay, can everyone see that? Okay. All right, so I'm incredibly honored to be on this panel with Dr. Dong, who I consider a mentor of mine, particularly in the early part of my interest in elder abuse, and I owe him a debt of gratitude for his advice as a geriatrician in geriatrics, and he's certainly a pioneer in Asian research. So we need more people like him. So I just wanted to start off like that. So I'm going to be speaking a little bit about our work in elder abuse, particularly during the COVID-19 era. In terms of background, I'm a board certified clinical neuropsychologist, and I got interested in financial exploitation, which has been the focus of my research for the last 10 years, really because I started seeing in the clinic patient after patient referred because it was discovered they were being financially exploited, and the presumption was that they had early cognitive impairment or dementia. And so we would do hours of testing, and they would actually turn out cognitively intact. And so this was puzzling to everyone involved, certainly puzzling to me. And so this started a program of research, which started while I was at Rush, affiliated with the Rush Alzheimer's Disease Center. And so we've published a number of papers to date trying to focus mostly on the brain and what changes in the brain that might make an older adult more susceptible to financial exploitation. This program of research was funded by something called the Beeson Fellowship. And this Beeson grant, Dr. Dong was a named mentor, which is why I owe him quite a bit. I was also paired with Mark Lax, who we mentioned as an outside mentor. And Mark Lax and I published a paper because the first time we ever met, we had a conversation about these cases that we saw in clinic, where case after case, there was a presumption that this was an early dementia because it was discovered they were being financially exploited, showing poor financial decision-making, and case after case, it was the case that they were cognitively intact. And so, and we were working in different parts of the country at the time. We were having very similar experiences. And so this is something that we coined a term called age-associated financial vulnerability, wondering if there are certain older adults, not all older adults, but certain older adults that might be more at risk for scam and fraud. And it's in talking with Mark and others like Dr. Dong in the elder abuse world that I really started to develop an interest and respect for considering factors beyond the actual older adult. So beyond the brains or brain changes that might make an older adult more susceptible to scam or fraud. And so in this paper, we talk about medical and functional, psychosocial, environmental considerations that might be involved in making an older adult more susceptible to scam or fraud. And in talking about this in the context of and with respect to the elder abuse work that has been done, Mark actually introduced me to Laura Muscada, who recruited me to USC. And so Laura Muscada is the head of the National Center on Elder Abuse. She has a wealth of expertise on all things elder abuse. And it's really under her tutelage that my knowledge about all the factors that could influence or lead to elder abuse really grew. And so when we're talking about elder abuse, there are a number of definitions out there, but the World Health Organization has this one. It's a single or repeated act or lack of appropriate action occurring within any relationship where there's an expectation of trust, which causes harm or distress to an older person. So this can take various forms, such as financial abuse, physical abuse, psychological abuse, and sexual abuse. It could also be the result of intentional or unintentional neglect. And Laura Muscada actually is credited with developing this conceptual model to try to understand all the factors that might contribute to elder abuse. And in this conceptual model called the AIM model, or the abuse intervention model, there are three major considerations. There's the older adult that is vulnerable. There's the trusted other, the person that's committing the abuse. And then there's the context in which the abuse is actually happening. And really, there are a number of factors that could come from any of these three major considerations that can contribute to elder abuse. And so I and others have found this a useful way to think about and also think about potential interventions for elder abuse. So this broadening of all of the factors that could contribute to elder abuse is something that informed our current study focused on financial exploitation, which we're calling FINCHES. And so this is the Finance, Cognition, and Health in Elder Study. And in addition to potential brain changes that might be of interest, we're also looking at other contextual factors to see what may lead to a particular case of financial exploitation. We've published a few papers on this so far. One is that we found that in older adults, and I should say in our FINCHES study, we're studying older adults who have no cognitive impairment. And this is because, again, those cases that I saw in clinic where we saw older adults where there was a clear change in financial decision-making or financial susceptibility, but they had no cognitive impairment. So in this study, we found that older adults who have no cognitive impairment, but reported a financial exploitation experience, had higher depression symptoms, higher anxiety symptoms, and also had worse sleep. And so you can imagine if an older adult is experiencing these things, they might be more susceptible to scam or fraud. In a recent paper published by my current postdoc, Dr. Jenna Axelrod, we saw that older adults who reported a financial exploitation experience had higher frailty. And when we drilled down into what actually led to this, it was really higher or poorer vision and poorer hearing. So again, you might imagine if an older adult has poor vision or poor hearing, they might be more susceptible to financial exploitation. And in a recent paper from my former postdoc, Dr. Gali Weisberger, who is now a faculty member in Israel, we're still interested in potential brain changes that might happen ahead of any noticeable cognitive decline. We do believe that this could be the case. And so this is a recent paper that we published on that topic. Now, this broader appreciation of elder abuse work is something that led to this current paper here. The National Center on Elder Abuse is a great resource that we have at USC, and the offices are literally right across the hall from my office. And so they're great people working to really try to push out the idea that we need to be more aware and address elder abuse. And they have this resource line where people can call and actually ask for resources about elder abuse. And for many years, they've been collecting anonymous records of these calls. They're completely de-identified. And I said, is anyone looking at that resource as a research data set? And no one had at the point. And so we actually looked at this over a 2-year window and looked at the types of calls to really report on trends in elder abuse over that 2-year window. Incidentally, the resource line is here just in case you want to reach out at any point. So everything I've talked to you was work that we had either been working on or started, and this was before March 2020. And we know that in March 2020, that's when the pandemic hit. So there was a national lockdown, everything changed for all of us. There's not a single person that hasn't been affected by this pandemic in one way or another. And I want to acknowledge that. And it's an incredibly devastating pandemic for multiple reasons, particularly for older adults. I and many others, like Dr. Dong, were worried about elder abuse because we know that there are risk factors for elder abuse, and we knew that they would be exacerbated with this new pandemic. And so what do we know so far? So the Federal Trade Commission put out 2 warnings, actually a third, from what I know, about an increase in COVID-related scams. We know domestic violence rates increased in China and Spain. Older adults were involved in some of those stories. The CEO of a Canadian organization called CanAge reported a 10-fold increase in elder abuse reports. And then an international organization called HelpAge reported a disproportionate increase in elder abuse in places throughout the world, like in Nepal, Democratic Republic of Congo, Jordan, Kyrgyzstan. So it's starting to look like what we feared. Early on in the pandemic, Laura Muscada and I penned a letter to the Journal of the American Geriatric Society, where we brought the AIM model to bear to help try to understand what are the potential risks that might be exacerbated during the pandemic. For example, in terms of the older adult, we know that COVID particularly hits older adults harder than any other age group. We also know that social isolation creates greater dependency on others during this time. In considering the trusted others involved, we know that a number of programs shuttered because of the pandemic, resources shuttered. And we know that people have been taking opportunistic advantage of others during this time. And then finally, in considering the contextual factors, ageism, I would say, is rampant during this time. It's been truly sad to see such ageist sentiments expressed during this time. So this letter actually got a lot of attention in the press, and so PBS and others have highlighted this. And our hope in doing this panel, supported by the Roybal, we really want to get the word out about this, that elder abuse is something that we want to try to address and try to look out for, try to prevent, because we know the risk factors are going to be exacerbated during this time. The World Health Organization cited the letter actually in one of their international public policy statements. And so again, we're just trying to highlight during the pandemic, elder abuse is a risk. It's a higher risk. And so the more that we can do to address this, the more we can try to head things off. I get asked all the time, what are some suggestions, concrete suggestions we can do? I think family members and loved ones should check in regularly with older adults. Older adults should not be shy to reach out to supportive resources. It may seem like things are shuttered, but from what I've seen, a number of resources have just tried to pivot to try to make themselves more available over phone or over internet. Please try to keep reaching out if you're an older adult. If you experience a scam or fraud, please report it to the authorities. Don't get rushed into making a final decision during that, financial decision during this time. Be more cautious about internet and online opportunities. We're all more dependent on the internet right now. We're all more dependent on electronics. That could create a potential risk for exploiters. This next one's a sensitive topic, but I would encourage you to make sure your affairs are in order. My wife is a lawyer. One of the first things early in the pandemic, she said, is we need to revise our will, or we need to update our will now because we don't know how this is going to impact us. And so that's one of the things that we did. And then a long-term goal, I would say, is addressing ageism. It's been truly disheartening to see the ageist sentiments during this time. So that's something that I think we need to work on. In terms of resources, 911 is still active, so please use that as a resource if you're in immediate danger. Also, local adult protective services have pivoted. They're trying to make themselves available. The FBI has IC3, which is a way that you report internet crime. The US Senate has started a new fraud hotline. This is actually the website for that. The Better Business Bureau has a scam tracker, and so that's online as well. And then I mentioned before, the NCEA resource line is a resource. So in summary, the COVID pandemic presents multiple threats, but I would argue multiple opportunities to address elder abuse and neglect. These interventions might benefit from considering these three major considerations: the vulnerable older adult, the trusted other, contextual factors. We do need more hard data, as Dr. Dong said, on how the pandemic has impacted elder abuse and neglect. We don't have that yet. And we need more research, more studies on that. We also need more input from aging experts on the pandemic policies. And I can't stress this enough. There are a number of people making decisions on behalf of older adults, but I think older adults need representation on those decisions. And I think aging experts need to be part of that discussion. So in terms of future directions, I mentioned the research study where we're looking at the National Center on Elder Abuse resource line. So we are actually working on a study that looks at how this has changed during the COVID time. This is under peer review right now, and I look forward to sharing with you the results once it's accepted for publication. So there's a number of people I need to acknowledge. Laura Muscada at USC is a tremendous resource for elder abuse. There are a number of elder abuse researchers at USC, and Bonnie Olson, Kate Wilbur, Zach Kasumis. There's a number of us here that have been trying to tackle this, particularly during the pandemic. My collaborators throughout the country and my current funding. So that's all I have. Thanks.
Thank you, Dr. Han. Let's give a round of virtual applause to our two great presenters.
Real, very much.
Thank you so much. This is a timely topic, as I said earlier. The issue of elder abuse and maltreatment really permeates our society in ways that many of us are not cognizant of. We do appreciate the insight that were shared with us today. Now, this is the part of the schedule of our roundtable where we open it up to questions and comments from the audience. I know we're over 140 attendees. That's great. This really shows the interest that we see not only in the academic circles, but in our provider communities as well. Is there anyone that would like to pose a question or comment to either Dr. Hong or Dr. Dong? Pamela, I think I see your hand up.
Okay, great, thank you. I have been a patient advocate for elders who are living in assisted living facilities. And I have been amazed at the lack of real care and support. And I'm just wondering about the governmental bodies or possibility for more protections, because I mean, these people are paying for care and they're more than likely, unless they have extra money, going to be neglected.
Yeah, thank you, Pamela, for your question. And I think just to take a step further is not just the assisted living facility, but also long-term care facilities as well. You know, people moving to those facilities because they either need a lot of care or need a little bit of care, or for personal preference, they don't want to deal with a large house or whatever that may be the case. And I think COVID regulations have made it very difficult, but that's not an excuse for not able to be able to provide support. In the nursing home, in the assisted living facilities, I can give you some of the examples in New Jersey that the protocol just, it completely locks down. No family can visit, testings, isolations within their rooms becomes increasingly the case. And not only have physical consequences in terms of mobility, disability, frailty related issues, social related consequences, but also caregiver. You know, it makes it, and I think gets back to what Duke's saying earlier about in terms of ageism. You know, that sense that this population are more likely, we're going to assume that they have it, so we're not going to do the same as we normally would do. That's really a systemic issue, and I think they really require multiple levels. It's not just the fact that the family, but also facilities and policy level. And I think from a family level, that, you know, if the elderly do have family in the assisted living or long-term care facility, there are other ways we can still keep them connected. You know, in Pennsylvania recently, there's a group of high school students who was gathering, you know, unused iPads and donating them to assisted living and the nursing home facility residents and setting up for them so they have a way to communicate with their family members. And I think from a facility perspective, I think there needs to be more, especially regarding testing. You know, we do a lot of testing, but we really don't know a lot about testing in terms of sensitivity, specificity, how good the tests are, how often we should do those tests, when is the most effective. We know a lot more than we did before. Earlier phases was more of a shot in the dark, and now we know better. But the new variants causes a lot of different uncertainties in terms of guidelines and who's going to pay for them from the facility perspective.
Are you talking about cognitive testing or are you talking about COVID?
COVID testing.
Okay, but aside from COVID, because that's a whole other layer. You know, the issue of not getting proper care, of not maybe, I mean, I would, if maybe you could tell me what are the policy issues, like how would you take this to a policy level?
Mm-hmm. In terms of regulations, you know, what are the rules? Nursing home, give you an example, it's probably the most highly regulated industry next to nuclear plants. You know, they're incredibly highly regulated. But I think in the current environment, Pamela, we can't isolate just talking about, you know, proper care for older adults in assisted living facility without mentioning COVID. I think prior to that, I think there's certainly issues that faces, but I think COVID exacerbates it because of visiting rules, testing rules, hospital admission rules, you know, hospital re-entry rules back to the assisted. There's some assisted living facilities are refusing to take older adults back to their facility because of concern for contaminating COVID in those cases. So I think, you know, there's a lot of issues has to face, but I agree with you that I think more needs to be done.
There are questions that Edie's, you're going to read off some questions that are being posted. While she's doing that, XinQi, what are some tools that people can use to assess the risk for or the presence for abuse, maltreatment? That's some of the questions people are asking.
Right. So there are validated tools that's being used. There are VASS is one of the tools that's out there that you can screen. There's about 8 to 10 questions that we can use to talk about vulnerability, dependency, some of the conceptual framework that Dr. Han was talking about. There are ways to also, I think, just have conversations. You know, there are things we need validated screening tools for, but sometimes it's just nice to have a conversation with the person just to say, are you safe at home, right? Are there conflict that occurs that exacerbates into verbal arguments? Do those verbal arguments ever lead to physicality? Do you ever feel unsafe at home? So there's a lot of different ways we can talk about issue, but we have to feel comfortable talking about them. You know, many of us don't feel comfortable talking about these intimate issues. So I think that's where the awareness will lead to care, care will lead to discussing those topics, so we can start asking those questions. Duke, you do a lot of psychometrics, and what are your thoughts?
There's not a lot of, from a strictly psychometric standpoint, there's not a lot of measures out there that I am aware of that are very robust. And so I think what Dr. Dong has mentioned about just simply having a good conversation where someone feels comfortable sharing, I think that at least based on my clinical experience, that seems to be more effective than using any sort of established tool at this point. But that being said, because there's no, and one of the things I'm trying to do more these days is trying to see where there are gaps and trying to turn it into an opportunity. So we know that there are gaps and that we need better tools. And so we need psychometrically established tools, stronger tools to help address and assess for elder abuse.
Thank you. I'm going to read one of the questions that came early on, and then Susan P. Strick, I see that she raised her hand a little while ago. So are there any data sets that address elder abuse and the undocumented population?
I saw that question earlier. It's a great question. I'm not aware of any research that's been conducted in this area. I don't know, Duke, if you've come across anything.
Yeah, no, I would agree. That would be a great avenue of pursuit for sure.
Although I can tell you that we're about to launch a study in New Jersey looking at immigrant population. So we're looking at 8 different immigrant groups more specifically, and we will be asking questions about documentation. Certainly with the subject to IRB approval and fully informed consent. We're working with a number of refugee asylee groups in the state of New Jersey. So we recognize that's a deficit and think there are people who really care about this population.
Susan, would you like to post your question? Susan Strick. While she comes on, I'll ask the next question is, can you share resources on how to ask about abuse over the phone? Is the only thing to do is to call 911?
Duke, you want to take that? Because I think you're involved with the NCEA, makes a lot of sense.
Yeah, so I think the NCEA has a resource line where if you're looking for ways to report elder abuse or different ways to address elder abuse, they will be very helpful. So if you contact the resource line, I don't have the number in front of me right now, but it's in my presentation, which I think was posted to the chat. They'll be able to at least point you in the right direction. That's their role, essentially, is to help people identify more resources for elder abuse, potential ways of reporting it, if there are different ways of reporting it. So there's not just 911. Typically, I think 911 is more of an emergent situation, but they should be able to help you at the NCA for sure. There are other resources I know, so I just don't have them in mind at this point. So yeah.
And the next question is, are tech methods being developed to monitor on-site care relationships in the various care environments?
Do you mind repeat the question? I didn't hear it fully.
Sure. Are there technology methods, they put tech, I'm assuming technology methods, being developed to monitor on-site care relationships in the various care environments?
Yeah, Dr. Dong mentioned this, that the use of iPads, I think, are becoming more frequent in particularly long-term care facilities. And I think it's a way to establish and maintain contact with family members and loved ones. There are other initiatives to get cell phones and smartphones that I know of. And then there's proactive programs where groups of students, for example, at a school are proactively contacting older adults. So there is definitely a higher utilization of technology methods to try to address particularly social isolation during the pandemic. And I think they're all great, frankly. We just need more contact because the pandemic has reduced contact.
Related to that, I also see Robin Newman had a question about as well about technology and camera. There are states who have very specific permissions to be able to put video cameras in common areas of the nursing homes or perhaps assisted living facilities to be able to monitor. There in Illinois, there was actually a law passed to actually permit cameras in older adults' rooms to be able to monitor their safety related issues. Of course, there are rules and regulations needs to be passed. We actually have a federal funded grant right now looking at the concept of using it's a clinical trial looking at a real camera versus a fake camera, and whether that actually reduces elder abuse recidivism. Because the fundamental premise is that, you know, if you see a police car on the side of the highway, you tend to slow down, right? If you see a camera, whether it's real or not, in the corner of the room, you tend to think about what you say a little bit differently. So the premise was that, so could a fake camera just as effective as a real camera in terms of reducing high risk, volatile situations in elder abuse homes? So this study is still being conducted. We don't have data yet.
Janet Morris, you had a question?
I just posted in the chat room that in I haven't been here the whole time, so forgive me if it's duplicative, but in California, we have a elder abuse restraining order, which allows an immediate kick out of an abuser, and you don't have to go through the normal eviction process. And a lot of people don't know about it, and it's a very useful tool when the abuser is living with the elder. Just wanted to make that.
Yeah, thank you, Janet. And I think this is something that Dr. Dong mentioned before, is the real impact on policy and you know, getting involved with pushing for more you know, political methods to address some of these issues. I think you know, a lot of this comes down to policy, and Dr. Dong is an expert in that. So again, this is a cause I think a number of us can get on board with, is protection of older adults and increased protection of older adults. And so it's not just through medicine or some of these other methods. I think it really does call for getting politically active.
Thank you.
And there's a question about the Medicare.gov ratings of nursing homes. Are they accurate?
You know, there are a lot of variations within them. I think the ratings are ratings, but I think, you know, it depends on what you want to do with those ratings, right? If you are using those ratings to decide which nursing home to put your loved ones in, the numbers only means one thing. You really have to see the facilities. You really have to understand that just because of a good rating, you know, a lot of the work that I do in terms of health disparities, looking at different, you know, underserved and minority ethnic groups, that they needs to fit, you know, they needs to fit with their needs. So I think it really depends on the context of the question. What do you hope to get out of it? And for, you know, for example, some of my, you know, Chinese patients, they may not want to go to the best rating places that are 20 miles away from the family members. So there's not just ratings, the logistics, it's about everything else that comes with it.
Thank you. Can refusal to comply with CDC recommendations by family be considered abuse, such as not wearing a mask around older adults, not informing the older adult that they tested COVID positive?
What has NCEA been doing on that part? Because I know that's highly controversial. Think about, you know, who and when and how.
You know, honestly, it's a tough question. I don't know, frankly. I think you can contact the NCEA.
I can understand the premise of that question. And I can even postulate to say, well, you know, is inadequate protection of older adults during the era of COVID considered a form of neglect in those cases? But that's complicated, right? Because there are cases that may be the case. There are cases where you want to put the mask onto older adults, either because they have respiratory conditions such as COPD, asthma, who can tolerate it, or people on oxygen, or people with dementia, right? It gets at the issue with which, Duke does a lot of work in terms of neurocognitive issues to say, when is the right time to be paternalistic in this case, if I can sort of interpret that with the question into the next level to say, can we really, what should we do, in the best interest of it's a bit of an ethical question as much as an elder abuse and related question as well, to say, when is the right time? There will be right times where it is an obligation to make sure that, my parents have all the PPEs that they need to be able to go to places. And yet at the same time, if they say no, then when do I supersede that? When do I give them a hard time? And to be able to try to convince them, probably no different in those cases than when I take care of a patient who is diabetic who doesn't want to take insulin. I don't give up on them. I don't scold them. I don't label them as non-compliant. I keep on working with them to be the case.
I'd like to ask one question or a question or maybe a comment. As a practicing social worker, I've been in situations where I've had to make elder abuse reports. And there have been some situations where I've actually gotten authorities involved, such as the local police department. And I'm quite taken by the fact that I get certain responses like, well, why don't we look at another type of violation or infraction? Because, elder abuse, that's kind of, quote, wishy-washy. And I was taken aback by it because it wasn't seen as the central reason why a criminal complaint would be levied against somebody. It was seen as something extra, maybe even deflecting from the real crime, so alleged crime, etc. Have you had that type of situation before? Has that been a topic of discussion in the elder abuse world?
No, that's a great question, Maria. It really speaks to sort of multiple level issues. I think the first is about who are the APS staff and who are the people doing the training and what are they responsible for? And there's a lot of variation. There's not a lot of training before they become APS staff. So there's a lot of the knowledge base is missing to think that they do the home assessment and make a determination. However, when you look across the states, there's a lot of variations in terms of determine or substantiating what constitutes elder abuse. Every state statute is different. Even though national, there's a law, but it all come back down to the state. And so the substantiation process or the determination varies greatly. And some states bars very low, some states bars very high. In the circumstance that you talk about, perhaps it's a state that have a much more strict law to say you need to provide documentation for those 10 things before I can. In many ways, that's the APS staff's job to be able to do that. The bigger issue that I face when I see patients in the clinic is that often because of the privacy and HIPAA related issues, we report the cases, but it's hard to get information back. And they often cite HIPAA as the way for which I cannot give information back to you, even though I'm the physician that reported the cases. And that's incredibly frustrating because, I reported the case seeking help because I can't do everything. But when the patient come back visit next time, I don't know what happened. I have to rely on the patients who sometimes may be cognitively impaired or family members who often may be perpetrators. That is very frustrating at times, yes.
Yeah, and I'll just add my 2 cents that I completely agree. I think, and I think the more I'm in this work, I'm starting to appreciate the broad impact of having clearer laws or clear legislation on this. And I think one of the reasons why, certain law enforcement may be not as willing to pursue cases is because this sort of potential gray area, or it seems a little bit unclear. But if we can actually work as a society to make sure that elder abuse is just completely clear and that it's something that needs to be prosecuted, it really does call on more of us to be more active and trying to make that happen. I think in the clinic, I share the same frustrations. There are times where I really want people to intervene, the authorities to intervene, but I don't know what happens. All I can do is report and hope for the best. I wish more things didn't potentially fall through the cracks, and I think that's where we can all work together more to try to address these things.
Thank you. It is a multi-level issue. Thank you so much.
We have a couple of other questions in the chat. One, it comes from someone that provides caregiving services. Is there any information on how to identify potential abusers or abusive situations?
Yeah, no, that's a good question, and very limited information. Some of the previous surveys have done look at especially caregivers of people with dementia. Some of the study that I cited earlier, although it's a small sample size, suggesting that 40+% of the caregivers themselves have admitted to abuse, neglect, exploitation for people with dementia. And I think that's, again, going back to what I said earlier, having that conversation. Caregiving is incredibly hard. Caregiving is incredibly frustrating. Caregiving is incredibly expensive. Caregiving is emotionally and draining, and really being tapped, especially for caregivers who have young children themselves. They're being tapped on both ends, and that's really hard. And I think as much as we want to understand and be able to report and find the right consequences for those cases, there are also cases where we need to be able to find ways to be more supportive to them. And because while there are many elder abuse are very malicious, intentional, and there are other cases just because they're frustrated, don't know what to do. And I think acknowledging both ends, having those discussions would be a good starting point.
Yeah, absolutely. I agree. I think, there's a context to everything, right? So, there's concern, obviously, for the welfare of the older adult, but we do need to be more concerned about how caregivers are taken care of. There's a lot that they're doing. So, and I think, certain government agencies are starting, I think, to show more interest in caregivers. There's more calls for research on caregivers at the NIA, for example, NIH. So I'm heartened by the fact that I think more people are starting to turn to the experience of caregivers. And I think, this sandwich generation, as Dr. Dong mentioned, where you're caring for children and also caring for older adults, there's a lot of stress behind that. So yeah, we need more resources for sure.
Jessica, you have your hand up.
Yes, thank you. This question is for Dr. Dong. If you could please clarify what you were saying about low-level support and it being associated with, I think you said the percentage was 8 to 15% fold mortality rate. Was that correct? Did I get that correct?
I think if mortality rates are 8 to 12 folds in terms of, depends on what type of elder abuse you're looking at. Those numbers relating to elder self-neglect cases. When you look at the overall risk for mortality for elder abuse, and it goes anywhere between 2 to 5 folds. Depends on which set of the population, which subtypes of elder abuse you're talking about.
Thank you.
We have another question from someone that works with homeless elderly. Are there resources helpful for them?
In terms of elder abuse, I assume?
Yes, elder abuse, yes.
Okay.
The question read, homeless elderly, they are at the bottom of the totem pole. Sometimes it is really hard to find resources for them. Are there any specific helpful resources for them?
I think that's a great question for the NCEA. I will say that our department has a very active homeless medical care group, actually. And so that's in the Department of Family Medicine. at USC. It's headed by Brett Feldman, and I think he would be a great resource as well to reach out to about this. So those are just two off the top of my head, but there needs to be more for sure.
And every state, every county often have additional resources. So look not just to adult protective services, look for, administration on aging, the administration for community living, some of the county area agencies on aging, to provide additional supports for elderly as well.
I have a question in regards to APS. I have approached APS during the COVID, and they're very limited. They cannot come out to assess anybody. And so that's been a big challenge to get APS to come out and, to assess situations that are very difficult for the clients. Any suggestions for that?
Yeah, that's a really important point. We talk about frontline workers as doctors and nurses and EMS people. People like social workers who do home visits, APS people are also frontline workers. I think we need to acknowledge that. I think we haven't done as good a job doing so. There are things you can do over the phone. One of the things that APS do most states is that they make unannounced home visits to be able to understand situations. Obviously in COVID, it's hard to do so. It depends on where the elderly may be. There may be times where if someone's discharged from the hospital, you may be able to have the APS staff to go visit the elderly in the hospital where the proper PPEs are more abundant, where the guidelines, is such that they can be cared for. But if short of that, I think technology can only take you so far. There are things where you need to have someone to have a conversation due to hearing, vision, cognitive problems. Often you can't do that over the phone, right? You can't do that over the web or Zoom, or they don't have access to Zoom in those cases. I don't have a solution to this problem, but I think there are some states are different. So if you take Chicago, where I spent last 15 years before I moved to New Jersey, there is a system called 311. It's a city level service that provide well-being checks to older adults, sort of using a team approach level, and not just APS, but firemen, EMS staff, postal workers, utility people to be able to make assessments who may need access in their home at the first place. So tag onto this as issue, something requires coordination and training.
Thank you so much, everyone. We're actually at the end of this excellent presentation. We do want you to still keep connected with the Roybal Institute on Aging. I am really happy to hear about the interest in family caregiving. In fact, at the Institute, we actually do a lot of research and clinical training in this area. So please keep connected with us. Post your information on social media in terms of anything that you gleaned today to our regarding our presentations. And I'd like to give another round of applause for our speakers today. And I thank you
so much.
I thank everybody for being present, asking a myriad of very key questions. Our roundtable was recorded, and you do have a copy of the presentation in your chat box right now. So thank you again. Thank you for being connected with us, and we look forward to sponsoring another roundtable very soon. Thank you.
Thank you guys very much. Great to be with you all. Have a good day. Be safe.
Yes, thank you, everyone. Take care.
Bye-bye.
Bye-bye.
Be safe, yes.